Hi, and welcome to this Pulsenotes lecture. I'm Ben, and I'll be taking you through acute coronary syndrome. So acute coronary syndrome is a medical emergency that's an umbrella term for three conditions. That's ST elevation myocardial infarction, non-ST elevation myocardial infarction, and unstable angina. So the ST component refers to the classic ECG changes seen in acute coronary syndrome, and myocardial infarction is the official term for a heart attack, where there's an absence or reduced blood supply through the coronary arteries leading to ischemia and subsequently infarction, which is death of cardiac tissue. So the coronary arteries supply blood to the heart. They're composed of the right and the left coronary arteries, and they arise from the aortic root. A reduction in blood flow through these arteries will lead to acute coronary syndrome. So the right coronary artery gives off the right marginal branch, it goes around the back of the heart, and if it's dominant in its supply to the heart, it will give off the posterior descending. The left coronary artery gives off the left circumflex that also runs around the back of the heart. And then the left anterior descending also comes off the left coronary artery, which runs over the top of the heart and predominantly supplies the left ventricle. Occlusion to any of these vessels can lead to acute coronary syndrome. So the principal mechanism of acute coronary syndrome is atherosclerotic disease, leading to plaque formation in the coronary arteries, which can then rupture and then lead to occlusion. So atherosclerosis, so patients with risk factor atherosclerosis are at risk of developing plaque rupture and acute coronary syndrome, including those with hypertension, diabetes, smoking, hypercholesterolemia, and a good positive family history. With these risk factors, there is endothelial dysfunction, so damage to the arteries and the inner lining. That leads to the recruitment of monocytes and infiltrates and are able to phagocytose low-density lipoproteins forming foam cells, which then sets up this inflammatory response within the arteries, and there's migration of muscle cells to the top forming a fibrous plaque and an atheroma. If there's rupture of this plaque, it's a prothrombotic event, which then leads to occlusion of the vessel and acute coronary syndrome. The predominant signs and symptoms of acute coronary syndrome are shown. The main symptoms of acute coronary syndrome is chest pain, often described as central, severe, crushing, and it can radiate into the arm or the jaw. Other typical features include dyspnea, which is breathlessness, and palpitations. Due to the profound sympathetic response from acute coronary syndrome, features of sweating, pallor, nausea, and vomiting can all occur. Typical signs of acute coronary syndrome include paleness in the patient, clamminess, there may be bibasal crackles, which is when you auscultate at the base of the lungs, you may hear crepitations or crackles due to the development of heart failure. And there may be also features of hypotension, so low blood pressure, and arrhythmias. So ACS is a medical emergency, and this necessitates a rapid assessment which is based on clinical features, ECG and troponin. So anyone presenting with chest pain, we need to do a rapid clinical assessment, which includes two principal investigations, an ECG, particularly looking for ST elevation in the early context of chest pain, and troponin, which is essentially a cardiac biomarker looking for cardiac myocyte injury. If we look at the ECG, there are typical features on an ECG suggestive of ischemia, which is due to a reduction in blood flow. So ST segment and T wave changes are associated with ischemia. It's critical in the initial assessment, as mentioned, to determine whether there's a presence or absence of ST elevation, as this changes our management dramatically in the early setting. So ST elevation, which is a rise in the ST segment above the isoelectric line, indicates a STEMI, which requires urgent transfer to a primary PCI centre for revascularization therapy. It's due to total occlusion of a vessel, which needs to be unblocked. ST depression is a classic sign of ischemia. It may be seen as a reciprocal change in the context of ST elevation. For example, if there's ST elevation in the anterior leads, we may see some ST depression in the inferior leads. However, if it occurs on its own, it's suggestive of ischemia and it's suggestive of an NSTEMI. So we need to look at the whole ECG. Finally, T-wave inversion is a non-specific change, which is when we get inversion of that T-wave occurring after the QRS. And it's numerous different causes as well as ischemia. It's important to note the location of the inversion and whether changes the dynamics, so taking serial ECGs to be able to properly interpret T-wave inversion. So looking at STEMI and STEMI unstable angina, we can do a diagnostic summary of the different features of them based on the extent of occlusion in the vessel, the ECG and troponin. So in a STEMI, there's total occlusion. We either have ST elevation or a new left bundle branch block, and the troponin is high. In an NSTEMI, there's non-total occlusion or subocclusion. There may be other features to ST elevation on the ECG, such as ST depression or T-wave inversion, and the troponin is high. In unstable angina, there's subtotal occlusion. There may be or may not be ECG changes, and the troponin is normal. So there hasn't been cardiomyocyte damage yet, but there's high risk of that developing. So we can use the troponin in the emergency department particularly to help rule in or rule out acute coronary syndrome. So in someone presenting with chest pain, the first thing we need to do is exclude whether this is a STEMI by excluding ST elevation and left bundle branch block. If either of those features are present, they need to go down the STEMI pathway with urgent transfer to a primary PCI centre. If those features aren't present, then we can start with taking a troponin at 0 hours. We then will get a result from the normal troponin, which will be normal or elevated. If it's markedly elevated on the first troponin, this is strongly suggestive of ACS, and we go down the invasive management with pharmacological treatment. If the first troponin is normal and it's been over 6 hours since the onset of pain, we can be happy this is unlikely to be ACS, and depending on whether they're pain-free, the risk they have of coronary artery disease, and we've excluded other diagnoses, we can consider discharge with or without a clinic follow-up. If we do the first troponin is normal, and the second troponin at 3 hours is also normal, we can go down that same pathway, make sure they're pain-free, low risk, and exclude differentials, and then think about discharge. If the first troponin is high, and the second troponin is also high with no significant change, this is suggestive of chronic myocardial injury, and we need to work out what the underlying cause is. Is it hypertensive heart disease? Is there a pulmonary embolism? We need to think of something else that could be going on. If the first troponin is elevated, and then the second troponin we see a delta change, this is suggestive of acute coronary syndrome, and we need to treat it appropriately. So a delta change refers to the percentage difference between two troponin results taken in the same patient. A delta change is troponin increase or decrease by a certain percentage which depends on the assay from baseline, and at least one result is greater than the upper limit of normal of detection. It is this delta change which is central to lots of diagnostic pathways in the emergency department for ruling in or ruling out acute coronary syndrome. So in a patient where we suspect acute coronary syndrome, we need to think about the initial management. So in suspected ACS, someone with chest pain, we do our initial clinical assessment. That involves airway, breathing, circulation, disability and exposure, as with all unwell patients. If we think they're stable, we can then take a brief history, perform an examination, do an urgent ECG to look for ST elevation or left bundle branch block. Then we can do observations, make sure there's no signs of shock. And we can do bloods, including a troponin, looking for cardiomyocyte damage, and that is essential to forming the diagnosis of acute coronary syndrome. So initial management is based on the mnemonic MONA. We can give morphine antiemetic for pain relief. We can provide oxygen if required, if they're not meeting their saturation. So typically, if they're less than 94% sats or less than 88 in someone who is a chronic CO2 retainer. And it's also important we get IV access. We can give some nitrates, usually sublingual, so under the tongue, to help improve coronary blood flow. If it's still severe, we can set up a nitrate infusion. And then we can provide aspirin. We load with 300 milligrams initially. And these 4 steps are all our initial management in people with suspected ACS. We can then look more specifically at the management of STEMI and then the management of NSTEMI and unstable angina. So in a STEMI, with evidence of ST elevation on the ECG, if the patient is presented within 12 hours of the onset of pain, and we can perform a primary PCI, which refers to unblocking the occluded vessel and applying a stent within 2 hours, then we go down the PCI pathway. So they need urgent transfer to a primary PCI centre. They're usually given a second antiplatelet, such as clopidogrel or ticagrelor, also loaded, and they may be given unfractionated heparin or low molecular weight heparin, usually at the time of angiogram. And depending on what they find at the angiography, they may be given other medications such as the GP2B 3A inhibitor. But this is really consultant guided. If we're not able to get to primary PCI within 2 hours, say it's an abnormal location, it's very difficult to get to, then we can think about fibrinolysis. So this is to use a clot-busting medication such as alteplase to try and break up the clot. And this is usually given in combination with clopidogrel and low molecular heparin or unfractionated heparin. It's important that we also get these patients to a primary PCI to undergo angiography within the next 2 to 24 hours. In the NSTEMI unstable angina pathway, there's a bit more time to play with. So it's all about the risk they have of significant cardiac disease. And this is based on the GRACE score or the heart score, which determines the risk of major cardiac event or death within a certain time frame. Patients who are very high risk, so those who have got cardiogenic shock, refractory pain, or development of arrhythmias or they've arrested, they need urgent management. Then there's intermediate to high risk patients, and then there's low risk patients. And we can follow the management based on the risk. So in all these patients where we're deeming ACS present depending on risk, initial therapy is another antiplatelet in addition to the aspirin as part of our initial therapy, usually clopidogrel, occasionally ticagrelor. We want to give fondaparin if there's no contraindications such as bleeding problems, which are usually 2.5 milligrams subcut. And we can also think about giving unfractionated heparin instead of fondaparin if we're planning to perform primary coronary intervention within 24 hours. But this is really guided by the cardiologists. So in someone who's very high risk, as we said, someone in cardiogenic shock or refractory pain, we want to try and perform cardioangiography within 2 hours. And then depending on what we find, we can either apply a stent or we may need to work them up for a coronary artery bypass graft. In those at intermediate and high risk, we should be performing coronary angiography within 96 hours, and actually the European guidelines suggest it should be within 24 hours. In those who are low risk, we can consider doing angiography if there's ongoing pain. However, if they're now pain-free, we may consider doing other ischemic testing such as an echo looking for regional wall motion abnormalities. If there's strong suspicion of ACS, well, then we go on to cardiac angiography. If all this testing is negative, then we consider discharge with further tests as an outpatient. So following acute coronary syndrome, it's important we think about secondary prevention, lifestyle advice and cardiac rehabilitation, as this is essential for all patients. And we can remember these factors by A, B, C, D. So with A, all patients following acute coronary syndrome need aspirin, so dual antiplatelet therapy in a combination with another antiplatelet such as clopidogrel or ticagrelor. They need high dose atorvastatin and need an ACE inhibitor. This is to help prevent abnormal remodeling of the heart. We need to provide bisoprolol, which is shown to improve mortality following acute coronary syndrome. And we need to provide cardiac rehab and tell them to cut out smoking. And in D, we need to give them driving advice and follow the DVLA guidelines. We need to address their diet, reduce their alcohol consumption, and we need to think about dyspepsia. So in those patients with pre-existing disease, we need to think about giving a PPI because we're giving 2 antiplatelets, which will increase the risk of developing peptic ulcer disease. So that completes our talk on acute coronary syndrome. We'll see you again soon. See ya.